Welcome everyone. This is Dr. Sharad Jaitly from New York, your cardiologist on your favorite website, MuniMeterHealth.com, which is dedicated to educating you about the human heart and its illnesses. We are on two channels, the Facebook and the YouTube. Hopefully you're signed on both. Without any further ado, I'd like to delve into the matter, but not before I have acknowledged your support, your enthusiastic interest in my cause of spreading this knowledge freely to all. I thank you again for being on MuniMeterHealth.com. So without any further ado, I'd like to delve into the matter of the subject. The subject of the matter being today, preoperative risk factors which will be assessed. So preoperative risk assessment basically, or risk stratification rather we can call it, in a setting where you have somebody going for non-cardiac surgery, if you will, and patient has some cardiac history. So now how do you assess a preoperative risk? How do you assess that patient who has somebody who has cardiac history and is going for a non-cardiac surgery, for instance? Well, there are 4 or 5 things that need to be evaluated. Number one, we need to know whether this surgery is elective or is it an emergency surgery, because it's very important that we ascertain that first. Now, if it's an emergency surgery, just remember that that patient goes to the OR directly. You need to just stabilize, optimize the meds, etc., and have the internist and the cardiologist both look at the patient to optimize the meds quickly, so without any further delay, let the patient go to the OR because the surgeon wants to bring that patient to the emergency room rather quick. It could be a trauma situation, it could be a vascular bleed situation, it could be a severe sepsis, impending sepsis from, say, appendicitis, or a ruptured viscera, ruptured aneurysm, etc., etc. So these are emergency surgeries where the patients go to the OR directly. So you need to just stabilize quickly and give the green light for the patient to go to the OR, because they're high risk, obviously, but they need to be operated upon. Now, the elective, I like to define elective because many times elective could be delayed and it could be also urgent. Now, urgent implying that it has to be done like within a couple of days, maybe the tops, maybe a week. Now, let me give you an example. Say somebody has a broken hip or a broken humerus, or say a spinal surgery. These are urgent matters. Obviously, they'll have to be taken care of. But the fact is that they don't have to be like overnight, like quickly enough. So you do have time, but limited time. And that's what I imply when I say urgent, because you do have time to really work these patients up. And the reason I'm mentioning that, and in my 35 years of my clinical cardiology practice, I've deciphered these terms, delayed and urgent. Now, delayed, I like to separate them out too. Now, the delayed could be like somebody going for prostate surgery. Now, those things like prostate, and many times you may have, say, a colon surgery, or those could wait out for a week or two, or even longer if need be, depending upon the symptoms, of course. But the fact is that these things can be delayed for a little longer period of time. So just so that you know, these surgeries, these procedures can be delayed, whereas the urgent obviously will have to be done within a matter of few days or even less than a week. So having understood what the elective versus emergency procedures are, I've just given you certain examples. Try to understand what the second part would be is, has the patient had any coronary revascularization? Now, this is very important. Why is it important? Because we need to ascertain if the patient's had a PCI, has the patient had a CABG earlier? And if yes, has it been less than 5 years? And has there been any recent coronary angiogram, if you will? So all of these will have to be ascertained first. So coronary revascularization patients, obviously they fall into different category of patients, but we need to ascertain, has that been done recently within 5 years, or has been done only remotely, like 10 years and over. In that case, we need to ascertain further factors. The third thing that immediately comes to obviously to your mind, and you need to answer that question, is, are there any clinical predictors? Now, having known that this patient has had PCR CABG in the past, that of course will define whether the patient has any angina recently or since, etc., etc. So the clinical predictors are very important. And we'll delve into those factors just rather very quickly. The fourth is the functional capacity you need to know. What's the functional capacity of that patient? Is the patient able to walk less than 2 blocks? Is the patient able to walk just barely within the room, or going to the bathroom and gets short of breath, or has chest pain? So these are low risk, there are intermediate risk, and there is a high risk. So the low risk is obviously where a patient is able to swim, play tennis, or climb the hills, if you will. So that's some excellent functional capacities, but that's the low risk. But intermediate risk, where the patient is able to walk about 2 blocks, barely about a flight of stairs, and get symptomatic. And high risk is obviously where patients symptomatic even at rest, or sometimes just walking within the room, or can't even carry on with the usual activities of life. So having said these, there's a fifth factor, do not forget that, and that is the surgical risk from the procedure itself. Remember, somebody is going for prostate surgery has a high risk procedure, has a high risk from the procedure per se, even though the patient may be a low risk in general. Okay, so surgical risk from the procedure, I always say, is very, very important to be ascertained as well. Likewise, you could have prostate surgery versus, say, somebody's going for cataract surgery. Now, cataract surgery has a very low risk, obviously, from the procedure per se, but the patient may be a high risk, so all of that will have to be looked at together. So it has to be very, very importantly looked at with all these 4 or 5 risk factors. Now, how do you ascertain when you have all these patients coming in with multiple permutations and combinations of various risk factors, between whether the surgical risk is involved, whether the patient has clinical predictors, whether the functional capacity is poor or high, etc., etc. So let's try to simplify in the next few minutes. So having understood the emergency surgeries are going for surgery, are going to the OR right away. So emergency surgery obviously goes to the OR. So that's it, done. Now, elective surgeries, that's where you need to answer these questions, whether or not this patient has had a coronary revascularization. If the coronary revascularization has been done, we need to know if it's been done in less than 5 years. If it's been done in less than 5 years and there are no symptoms, remember, no symptoms, this patient can go to the OR. Now, if the patient has had procedures done, say, between 5 and 10 years, and the symptoms are question mark, it's iffy, then patient should go for non-interventional testing, or we call non-invasive testing. So I put it down like in short form, non-invasive testing, regardless of the symptoms being ascertained, whether they are truly cardiac or non-cardiac. Now, if the patient has had no evaluation done but has some symptoms, obviously, that makes it a higher category, and that patient must go for non-invasive testing, and maybe perhaps even a coronary angiogram, depending upon what the functional capacity is, and we'll get to that in a second. So having understood this part, we need to answer the next question is, what is the what are the clinical parameters? Now, the clinical predictors, for instance, will define what further needs to be done. If the clinical predictors suggest that patient has unstable angina, or the MI was less than 6 weeks old, and or patient has a decompensated, we call it a decomp heart failure, or if the patient has had significant severe arrhythmias which have not been managed thoroughly, or severe valvular disease. If you have valvular disease and that has not been managed, now that puts this patient into high category. Remember that. Now, what is an intermediate category? The intermediate category will fall into the following way. Maybe patient has stable angina. Patient has had an MI which has been more than 6 months old and is stable now. A patient has had heart failure, but it's compensated heart failure, or has been treated well. No recent admissions in the past 6 months, so that'll give you an intermediate category or a signal there. Patients had arrhythmias and other problems like diabetes or hypertension, which have been severe, but they have been controlled, and they're all controlled well. So that brings you into the intermediate category. Now, the low risk is where you have somebody who has very, very mild angina. Somebody who has mild angina, for instance, somebody who has hypertension, but it's controlled, and somebody who has diabetes who is controlled. So these are various risk factors and do not forget the renal insufficiency here. That also puts somebody into the insufficient, in the intermediate category. Just remember that. Okay, now having understood this aspect, one really needs to know what the next question that you have to ask is, what is the functional capacity? Now, the functional capacity would be answered the following way. We need to ascertain, has the patient really been able to walk enough? If the functional capacity is low, that means walking less than within the room itself or walking less than 2 blocks. So that is considered as very low capacity. And then these patients need to be ascertained by non-invasive testing. Remember that. So these patients will require non-invasive testing. Now, functional capacity is intermediate, for instance, where a patient is able to walk about 2 blocks and the symptoms are present and the clinical predictors are suggestive of intermediate category. Then again, non-invasive testing will be required. But if the functional capacity is excellent, if you will, and that point, that patient will require no further testing and patient can actually go to the OR directly without any further testing. So excellent testing, excellent functional capacity will not require any testing. No testing is required, and therefore patient can go to the OR. As long as you have stabilized the meds and looked at other intercurrent illnesses that are present. So this is how you evaluate these patients. And of course, the surgical risk, as I said, becomes your fifth risk factor, and that needs to be ascertained too. And the surgical risk from the procedures per se, like the prostate surgery, for instance, like somebody going for carotid surgery. Now that's considered as intermediate risk. Prostate is considered as a high risk. Abdominal and thoracic surgery, for instance, they're all considered as high risk. And CNS surgeries and then spinal surgeries and carotid, I said they've been all intermediate category. But CNS and spinal, they fall into a high grade surgical risks. Cataract is a low risk. Breast biopsy, for instance, is low risk. You have, say, a local removal of lesion from the skin or superficial surgeries, biopsies, etc. They're all low risk. So these low risks, intermediate risk, and the high risk, as we just discussed, will also impact on your workup, on further guiding your algorithm, if you will, preoperatively. So in a nutshell, those are the 4 or 5 categories where you really need to answer those questions. Once again, to sum quickly, whether the patient is going for elective surgery versus emergency surgery. 2, has the patient had any coronary revascularization within 5 years? 3, is the patient having any clinical predictors like unstable angina versus stable angina versus mild angina, or decompensated heart failure versus compensated heart failure? Remember, if you have clinical predictors which are high risk, they must be evaluated by angiogram. Clinical predictors which are of intermediate risk must be evaluated by non-interventional approach. And clinical predictors which are of low risk and the patient is not going for a high risk procedure, can go to the OR directly. Number 4, you look at the functional capacity in the patient. And when you look at the functional capacity of the patient, like I said here, patient has low risk when somebody is able to walk more than, say, 2-4 blocks, climb the hill. So that's a non-interventional testing, may be required only for high-risk procedures, not for low-risk procedures. Somebody who's able to walk less than 2 blocks, regardless what the symptoms are, then obviously this patient will require non-interventional testing. But somebody who has extremely limited functional capacity, that will require coronary angiogram directly in that setting. So in a nutshell, you've learned all these risk factors, and of course, lastly, the surgical risk, as I mentioned just now, that will determine as well what the procedures are. So these are the 4 or 5 categories of questions that you have to assess prior to clearing the patient, so-called clear. I never say clearing the patient in my note, but I always define what the risks are, whether they are low risk, intermediate risk, or high risk. And that's how I always taught my fellows and residents as well, that you never clear a patient totally, because patients always have low risk. They're never no risk. Even a cataract patient, for instance, a breast biopsy patient, can have low risks for cardiovascular risk in a non-cardiac surgery as well. Once again, I thank you for your interest, and stay tuned to MuniMeterHealth for further newer videos coming up down the line. Until then, so long. This is Dr. Sharad Jaitly. Thanks.